Hi, my name is Travis Salway. I use he, him pronouns. I'm an assistant professor here in the Faculty of Health Sciences at Simon Fraser University. I primarily teach epidemiology and introductory epidemiology classes for both undergraduate and graduate students. The goal of these classes is to introduce students to the fundamental concepts in epidemiology as it relates to public health research and practice. So students come away with an understanding of how to pick up an article, an epidemiological research article, and how to make sense of it and understand how it would relate to their own work in the field of public health. So my research is broadly about the health of sexual and gender minority populations, and these include people who identify as two-spirit, as lesbian, gay, bisexual, queer, or transgender. Anyone who finds that their sexuality or their gender identity is outside of the majority. So anyone who's not cisgender or heterosexual. And my research is motivated by social epidemiology, showing us for the last few decades that these groups have a substantially greater burden of mental health struggles compared to the cisgender heterosexual comparator group. And we have a few ideas for why this might be. The predominant theory for understanding these inequities in mental health is called minority stress theory. And this theory suggests that minority groups, including sexual and gender minorities, are exposed to a higher burden of day-to-day stressors, having their identities doubted, having interactions rejected or dismissed because of their difference in terms of sexual or gender identity or expression. And so the research has kind of a discovery function. I try to look at what else is missing from that theory? What else could we think might explain that difference? So for instance, if I think about suicide, we see about fourfold greater rates of suicide in sexual and gender minority populations. So what else could be explaining that? And then on the community side, or the kind of the knowledge translation and action side, I try to work with community partners, healthcare practitioners, policymakers to figure out what could we do to start to close that gap, with the idea that it is very much achievable in the near future that in Canada we could have health equity for sexual and gender minority groups. Try to work with, I think of them as kind of three different audiences. So one audience includes policymakers. I think of politicians, I think of administrators, people who kind of set the rules that we live by. And most recent example of where my research has been used in policymaking is concerning this practice that we call conversion therapy. And so to go back to kind of my description of the research that I do, conversion therapy is kind of the sharpest edge of that minority stress phenomenon. So it's cases where sexual and gender minority individuals are put in positions to really consistently doubt what their true gender identity or sexual identity is. And those practices have largely been marginalized, have been discredited by, for example, medical professionals, psychological professionals, but we still see it showing up in pockets throughout Canada. And so over the last 2 years, I've worked with survivors of conversion therapy, with politicians and their staffers, and with LGBTQ2 community leaders to push governments to ban these practices. And most recently, we've seen the Canadian federal government, through Bill C-4, add provision to the criminal code to make it illegal for those practices to continue in Canada. I also work with healthcare practitioners, so that's kind of similarly looking at how can they make a healthcare practice, a clinical space that's inclusive and affirming of LGBTQ2 people. And then I work with LGBTQ2 communities themselves. I try to give them back the data that we're gathering so that they can apply for grants and get funding to support the work that they're doing. So what initially appealed to me about SFU, and in particular the Faculty of Health Sciences, and what continues to feel really good to me, is that it's not siloed. So in some other programs, other universities where I've been, we're defined as epidemiologists, and everyone kind of organizes themselves around what an epidemiologist does and doesn't do. By contrast here, I find you can kind of create for yourself whatever your niche is. So my training is in social work and in epidemiology, and I bring both of those things to my work, and that means it's not so easily defined into the silo of epidemiology or the silo of social work, but it's really fun because it gets messy and we get to think about what strengths do we want to borrow from each of those disciplines. I find that when I talk about my work to colleagues and students and other folks at the university here, no one questions like, well, why are you doing this project on conversion therapy if you're in a school of public health? People just are open to the connection, and I think that's a real strength of our community, that people believe in work that's interdisciplinary. People believe in work that's outside of the boundaries that we would find in other schools of medicine or public health. And it's something that I really appreciate.